So I just want to tell you a little bit about IIH, where there's a subset of IIH called the metabolic syndrome. Now this metabolic syndrome encompasses a lot of different presentations, and that's why it's a syndrome. It's not really a disease. The metabolic syndrome is polycystic ovarian syndrome, and it's typically, as you would expect, the same population as IIH, overweight young females. The difference is they have a slightly different presentation in terms of hirsutism and acne. They'll have the menstrual irregularities because it's hormonal, and they're going to have problems with the insulin resistance, and that might lead to diabetes. So when you see this combination on the chart, oh, I have IIH, but I also have hirsutism, acne, menstrual irregularities, diabetes, then we really want to look at the OBGYN evaluation and see if we're dealing with polycystic ovary syndrome. And the reason is, number one, this thing is a comorbidity that we would like to treat, and in these people, the combination of the metformin on our normal treatment seems to help both with the weight loss that we're trying to get for the IH, but also for the diabetes component. The menstrual irregularities also can be evaluated better, and you can have a single unifying diagnosis, as well as looking for the radiographic finding, which is the empty sella, which is related to this hormonal piece. And the hirsutism and the acne, you have to ask about that, because sometimes these patients are being treated with tetracycline derivatives or vitamin A analogs, which treat the acne but can worsen the pseudotumor cerebri. And so in those patients, it's nice to be able to tell patients, look, I understand why you're having difficulty losing weight, because you have a metabolic syndrome, not just because you have IIH. It's also useful to engage the other providers so that dermatology doesn't inadvertently make us worse by giving these eye